always a wonderful symposium and course, and I don't see Esper, but I will thank Esper once again for his great generosity. Those of you who have been to this course before or know my reputation know that I was trained as a cellular immunologist, and I've always been here talking about either CD4 or CD8 T cells and the lymph node. And after doing that for several years, I asked Esper if I could talk about something different, which are antibodies. Little did I realize that it seems as though everyone on the program wanted to talk about antibodies. I don't think there's a lot of overlap between the talks, but I think we've done a good job of breaking it up into different little compartments for you. So there's actually a long history of using antibodies in treatment. And this started actually back in the 1890s, before they even knew what antibodies were. But what they knew is that they could take serum and they could use that to neutralize toxins, specifically diphtheria and tetanus toxin. And in 1901, the Nobel Prize was actually awarded for this. And then what I show you here is, there it is. This statue in Central Park is of Balto. Now, you may not know the story of Balto, but in 1925, there was an outbreak of diphtheria in Nome, Alaska, in a really terrible January incredible cold snap, and children were dying of diphtheria. The closest antitoxin was present in Anchorage. And they had to figure out how to get that antitoxin from Anchorage to Nome, Alaska. The harbor where Nome sits was frozen in. It was too cold to fly open cockpit airplanes, and the train could only make it part way. So what they did is they got the anti-serum as far as Nanema, and then they organized dog sleds to take it the rest of the way to Nome. And Balto was the lead dog on the last leg. He was actually supposed to be the lead dog on the next to the last leg, but he actually got there ahead of when the next team was available, so he actually did the last two legs and got the anti-serum there in time. Now, Barney Graham gave me this slide, which he said is Balto's route, but that's not actually correct. So here's Anchorage, here's Nanana, where they took the serum off the train, and here's Nome, and Balto actually did this last stretch along here. But there was another dog, Togo, who actually took the serum across this stretch of frozen harbor, the most dangerous stretch. The owner of that dog was very upset for many years that Balto got all of the credit. But there's been a movie about this. In addition, this is the Iditarod sled race. So based upon this route, that's the route that they follow now for the Iditarod sled race. But enough about that. Let's move on to more recent times. So in 1975, Milstein and Kohler developed the techniques for making murine monoclonal antibodies and actually received the Nobel Prize in 1982. But as you heard from John Mascola, it's really since about 2008 that new techniques were able to be brought in to advance the field. And that's basically the ability to sort antigen-specific B cells, clone the immunoglobulin genes out of them, and create monoclonal antibodies. So in my talk, I'll first start by talking about an overview of existing broadly neutralizing antibodies, then talk about antibody engineering for better potency and breadth, then FC mutations and how they affect antibody function, and finally finish up with lessons from protection and treatment trials. So you've seen this slide before. There are 5 different sites on the envelope glycoprotein to which broadly neutralizing antibodies can be directed. This these are the multiple different broadly neutralizing antibodies that have been identified to these different sites. And here, circled, are those actual antibodies that are either in production for ultimate clinical trials or have actually been in people in clinical trials. So there are many, many broadly neutralizing antibodies that are on the pathway to clinical evaluation. I'm going to show you this slide several times. What this is a potency and breadth configuration for different antibodies. So breadth is on the y-axis, 100% breadth. So this means an antibody basically will neutralize every single HIV isolate that it's been tested against. And then potency is the concentration at which you get 80% neutralization. And so these antibodies that I show here are the ones that were isolated by older techniques. What you see is that they're reasonably potent. Some of them are quite broad, some of them are not very broad. And then the new antibodies that have been isolated since 2008, what you can see is that they're much more potent. They come out here to the right, and many of them are very broad. But what you also see is there tends to be this tendency towards those that are very broad being less potent. And as you increase potency, you tend to lose breadth. And ultimately, what we want is something out here. So this would be very, as broad as our broadest antibody and as potent as our most potent. So that's the goal. So let's talk about antibody engineering for better potency and breadth. How can we do that? I'll show you a couple of examples. So here's a different way of presenting potency and breadth. So in this type of graph, the more potent you are, the lower you are down on this graph. This shows individual dots for 208 different viruses. And these show the different antibodies. And then breadth is shown in terms of the percent of viruses that are resistant to each antibody. And what you see, I'll point out a couple of antibodies here. So VRC07 523. I don't show the parental VRC07 on this graph, unfortunately, but it was something like these CD4 binding site antibodies. So it had reasonable potency, but the breadth was not that great. But by doing antibody engineering, we could both increase the potency and breadth. There's also this antibody, 10E8 V4V5R100CF. So this antibody, here's the parental, was very broad. Only 2% were resistant, but it wasn't that potent. And through antibody engineering, changing amino acids, we were able to increase the potency about tenfold and maintain the breadth. So back to this slide, what you can see is here I show you VRC07, and here's the antibody that was engineered. So both increased potency and increased breadth. 10E8, here's the parental 10E8, and what you see is we've moved over. It stays just as broad, but we've increased the potency about 1 log. How else can we increase potency and breadth? Well, one way is just combine different antibodies. So another way of showing potency and breadth, here in this case, the more potent you are, the more you shift these curves to the left. What we're showing here is the median IC50 against a whole slew of viruses. This is probably about 200 viruses here. And in the bright colors are 4 different antibodies, all of which are pretty potent. The breadth of some of them is not that great. If you combine any 2 in brown, what you see is you increase potency and breadth. Any 3 in gray, you have even better potency and breadth. And in black, you get even better potency and breadth. And that's when you combine all four. So just by combining antibodies, we can get to the potency and breadth we want, but then you have to give 4 different antibodies. So can we get that kind of potency and breadth in a single antibody? And one way that you can do that is you can combine 2 different antibody specificities on the same antibody molecule. So this is from David Ho. What he did, and this is the cross-mab technology, you basically put one arm of the antibody, in this case against different neutralizing epitopes on the envelope. The other arm, he did antibodies against either CD4 or CCR5. And then what he could do is he could test for potency and breadth against a number of different isolates. And so here's the anti-CD4, here's the anti-CCR5. Here's one HIV envelope neutralizing antibody, and then combined with the CD4 or the CCR5 antibody. The same all the way across. And what I'd show you is this over here. So if you take 10E8, and now you combine it with either the anti-CD4 or the anti-CCR5 antibody, you get incredible increases in both potency and breadth. And that's also shown in a different way down here, where you have the CD4 antibody, the CCR5 antibody, and the 10E8. And then when you combine them, you get this huge shift to the left, and you're catching 100% of the isolates. So that's 2 antibody specificities in one antibody molecule. Our friends at Sanofi actually came up with a way of putting 3 different specificities on one molecule. And that's shown here. So one arm of the antibody is VRC01. The other has actually 2 combining sites on it. In this case, 10E8 or PGDM 1400. Now, when you look at this, it looks as though, well, this is going to be out at the end of the molecule. That'll be easy to combine with. But what about this epitope? That looks like it's sort of hidden on the stalk. But if you actually look at a 3-dimensional structure of it, it's not as it was previously shown. So here is the GP120 core binding to the VRC01 arm, so nicely exposed. And then this other arm actually has 2 specificities going here. So the MPER, this is in red, you can just barely see it. That's the MPER binding there. And this is the combining site for PGDM 1400. So they're actually, all 3 of them are nicely exposed. And then when you look at these different combinations, what you can see is by putting all 3 together, you get very nice increases in potency and breadth. So here are the different parental antibodies. If you combine them, you get very good potency. And the breadth, there are very few viruses that you miss. So because of manufacturing and other issues, it was decided to move forward with this combination. And this just shows you the 3 different arms in the purple, the red, and the green, and then the trispecific showing the increase in potency and breadth. So this molecule is actually scheduled to go into clinical trials hopefully later this summer. So just going back to this, what you can see is that with these tri-specific antibodies, we are now moving out and getting very close to this theoretical perfect antibody that we want in the gold star. Okay. So I've been talking to you about the combining part of the antibody. What about the other half of the antibody, the FC portion? So the antibody actually has 2 regions. I've been talking to you about these variable regions that actually bind to the different antigen targets. But there's this other half of the antibody, the FC region, the constant region, that does all sorts of other things. So it binds to FC gamma receptors, it binds to complement, and it binds to the neonatal FC receptor. There are a number of different mutations that have been identified that you can make in the FC region that, I won't have you read all of these, but that increase the affinity for the different FC receptors. And that could lead to increases in ADCC, antibody-dependent cellular cytotoxicity, antibody-dependent cellular phagocytosis, or complement binding. But before I talk about that, let me just talk to you about alteration in binding to the neonatal FC receptor. So here's the FC region. And it's actually broken into two areas, the region of the FC that binds to FC gamma and complement, or FC gamma receptor and complement. And then right in this hinge region is the area that binds to the neonatal FC receptor. So there are mutations that are known that have been made actually now in most of the broadly neutralizing HIV monoclonal antibodies that increase affinity for the neonatal FC receptor. And so just by changing 2 amino acids in this hinge region to a lysine and a serine, so this is called the LS mutation, you can get much higher binding to the neonatal FC receptor at acidic pH, which is present within the endosome. This protects the antibody from degradation, and then the immunoglobulin is released back into the circulation, and this results in a very prolonged circulating half-life. So VRC01 is an antibody that has been in clinical trials. We know it's PK. We made this LS mutation within VRC01, gave it to individuals, and this just shows you a comparison of the VRC01 PK, where it has a half-life of about 15 days, versus the VRC01 LS at 5 milligrams per kilogram. And you can see this much longer half-life, such that you can maintain greater than 10 micrograms per ml for 6 months. If you give 20 milligrams per kilogram intravenously, what you can see is that you're able to maintain greater than 50 micrograms per ml for 6 months. So now if you're trying to develop something for either therapy or protection with these LS mutations, you can give the antibody very seldomly, which just changes both the cost of the product and the ease of administration. Let me shift gears just a bit and now talk about these other 2 mutations. That would be the LALA mutation, which really reduces all binding to all the FC gamma receptors, or the DEL, which enhances binding. So this one really wipes out ADCC, and this increases ADCC. Why do we care about ADCC? Well, if we're talking about prevention, we're probably not all that worried about ADCC. We think that prevention probably occurs just through neutralization, though it is possible that ADCC is involved. But for treatment, it may be that what we want to do, and especially for a cure agenda, is as virus is budding from cells, we want to have antibody bind to that cell and then the NK cell come in and kill that cell. And so ADCC may be very important for treatment. But first, prevention. Dennis Burton has done a couple of studies looking at ADCC and its role in protection. He took antibody B12 and tried to protect monkeys from intravaginal infection with HIV. And what he found is that with the standard antibody, he got nice protection over those that got no antibody. If he made the LALA mutation, which knocked out ADCC, he tended to decrease protection a little, but not completely. If he used another mutation, this wasn't the DEL mutation, but a non-fucosylated form of the antibody, he did not enhance protection. So there's some question about the role of ADCC in protection here because of this, but I think the general consensus is that in certainly the HIV model, ADCC has no role in protection. But what about treatment? So if we're going to talk about treatment, we need to know about HIV dynamics in vivo. And so we have to go back to the original descriptions of HIV viral replication. And that came in 1996 from Ho and Perelson. And what they showed is that if you give, in this case, protease inhibitors, but if you can also give RT inhibitors, and what you see is that you get about a 24-hour delay, and then you get this log linear decrease in plasmavirus load. And they did a lot of modeling of this. This is from the original publication, this wonderful chart here, and it's all based upon this equation, which you'll be tested on later. But if we're going to understand how antiviral activity is being carried out, we need to understand this. But I would say that you really shouldn't be intimidated by the math. So let me just show this figure a little differently. So this is the same figure, just bigger. And really what the equations say is that this is the plasmavirus load. And it is maintained at a steady state because the rate at which this decays is equal to the rate at which it is being replenished. And during periods where you're not on antiretroviral therapy, the model says that 99% of this is being maintained by infection of activated CD4 lymphocytes that then spew out virus, and this just goes on. And this entire process takes about 2.6 days. These cells decay at a half-life of about 1.6 days. But what it also says is that these longer-lived cells or activation of latently infected cells supplying this, the plasmavirus pool are really very minimal. So we don't need to worry about the right side of the graph, just worry about the left side. So then, one thing that they understood from this is that if you give, let's say, a antiretroviral therapy, what you tend to do is block new infections. But all cells that had already been infected are going to continue to spew out virus during this period. So if neutralizing antibodies work by blocking new infection, you're going to see this same delay that you see with antiretroviral therapy. However, if ADCC is operative and you end up killing cells as they're producing virus, then you're going to decrease the amount of virus coming out immediately. In which case, the graphs should look like this. You should see no delay. You should see an immediate decrease. So, having given VRC01 to viremic individuals, this is Rebecca Lynch's paper, we could simply go back to the plasmavirus load data and we could look and we could say, look at this, within the first 2 days, you're seeing no decrease in plasmavirus load, and then it comes down. So this is very suggestive of the fact that neutralizing antibodies are acting just as entry inhibitors. But what about if we made some of these alterations to increase ADCC or decrease ADCC? So if we increased ADCC, we would start killing these cells off faster. So not only would there be no delay in the drop here, but you should actually see an increase in the slope of the antiviral effect. So what we did is with VRC07523, we made the deletions, either a DEL mutation that increased ADCC, you can see that here, or the LALA mutation, which completely wiped out ADCC. We infected monkeys, we waited till they were at steady state, and we gave these altered antibodies, and then just looked at plasmavirus load. Here are the data. We have 9 monkeys that got the DEL mutation, 8 that got the LALA mutation. There's the complete data. Let me break this down. If you look in the first 20, or before antibodies were infused, we were at steady state. In the first 24 hours, what you see is you have fairly stable levels. So what I've done here is take, for each monkey, we figure out what their baseline is, and we set that at 0. So that's right here. what you see over the first 24 hours, things bounce around a little, but really you don't see any antiviral effect. But after 24 hours, that's when you see not only the decline in viral load, but there's no difference whatsoever between the DEL or the LALA mutation. So what these data say is that there's no difference in delay or slope of the viral load decay with increased or decreased ADCC activity. So the in vivo antiviral activity of HIV broadly neutralizing antibodies is almost certainly related to neutralization and not ADCC. Having said that, there is this very interesting little thing we're seeing, which is in the first 6 hours, we see this dip, and we don't know what's going on there, so there's still a lot of work to be done here. Finally, what I've said is that in active virus replication, we're really looking at this side of the equation. But once you put people on antiretroviral therapy and really suppress them, you get rid of all of this, you get rid of all of that, and then any viral replication that's occurring is what's coming out of this latent reservoir. And that's where the cure agenda comes in. And the question still remains, is ADCC going to be important in attacking these cells and clearing them as they reactivate? And you'll probably hear from Stephen Deeks some more about that. So finally, in the last couple of minutes, let me give you some lessons from protection and treatment trials. There's been a long history of using antibodies to show that you can protect against infection in monkeys, but there's really no human data regarding passive protection by HIV monoclonal antibodies. Because of this, the HVTN and HPTN have put together this big trial called AMP, Antibody-Mediated Prevention Trial, to address the question, can a passively infused monoclonal antibody prevent HIV infection in high-risk adults? 3 objectives. To determine whether and at what concentration a broadly neutralizing antibody, in this case VRC01, can prevent HIV infection. Is protection attained at levels of neutralization that can be achieved by vaccine immunogen? And is protection achieved at a dose that can be administered subcutaneously infrequently? So it's really 4,600 individuals. It's 2 different groups of individuals, high-risk men in North and South America and high-risk women in South and East Africa. The antibody is given at 2 different doses, 30 and 10 milligrams per kilogram, and it's administered once every 2 months. Why 2 different doses? Well, with these 2 different doses, if you give 30 milligrams per kilogram, you know that your trough levels will be about 16 micrograms per ml. At 10 milligrams per kilogram, about 4 micrograms per ml. And this just gives you an increased ability to associate antibody serum levels with breakthrough infection. If this trial proves to be have a positive result and show protection, we'll be able to determine that sub-Q administration of antibodies, or determine the level of monoclonal antibodies given sub-Q that are needed to obtain the protection. It'll be an incentive to develop the next generation of monoclonal antibodies. VRC01 is not going to be a product, but if we now can develop broader antibodies that can actually be a product, that'll be good. We can have options for genetic immunization that you'll hear from Rhonda Rozier. And we'll have the knowledge that neutralizing monoclonal antibodies can protect, and this will guide vaccine field. Another consideration when you're looking at blocking transmission is how does transmission actually occur? You'll hear more about this from Tom Hope, but we assume that there's a lot of virus that hits the mucosal surface. There's this sieving effect, and very few virus comes through, and really all we have to do is get the antibody to block there. and that should be easy. But what if you really have to block at the mucosal surface, and if you do that, resistant virus may get through? Or what if that sieve is not so great and you get a mixture of viruses through? Then monoclonal antibodies may have a problem with transmission of resistant viruses. And which scenario dominates may be different depending upon rectal, vaginal, or other transmission. I'm going to quickly run through just a few slides showing you the clinical trials of individuals who were HIV infected. This is the first trial that was done with 3BNC117. What you see is you give the antibody, the plasma virus comes down, it then comes back up as the antibody goes away. If you have low viral loads, you're suppressed for longer. Just to point out, it also looks like there's a 24-hour delay here also. This is Rebecca Lynch's data, and once again, you infuse the antibody, plasma virus goes down, the antibody goes away, it comes back up. Those that start with the lower viral loads are suppressed for longer. These two that weren't suppressed were the ones who started with resistant virus. 101074, this is a V1 or a V3 antibody. You see the exact same thing. So in all of these, we're seeing the exact same thing. What about if we have people who are suppressed and we give antibody and say, can we maintain suppression? Well, a number of single antibody studies have been done. This simply shows you what happens with 3BNC117. You can give the antibody. After you take them off of antiretroviral therapy, you can maintain nice levels of antibody, and what usually happens is while you still have good levels of antibody, the virus comes back. Though sometimes the virus doesn't come back until the antibody goes down. When that virus comes back, in general, it's resistant to the antibody. When the virus comes back, it's usually resistant to the antibody. But you do get a delay in rebound, but ultimately you get resistant virus. Here are two trials done with VRC01, exact same thing. You get a delay in rebound, but you generate resistance. And so, in conclusion, there's really been rapid advancement of potent HIV-specific monoclonal antibodies into clinical trials. They've been classically used to prevent infection, and a phase 2b study for HIV prevention has begun. There are multiple phase 1 treatment studies that have been completed with single antibodies, but it's unlikely that single monoclonal antibodies will be able to maintain long-term viral suppression because of resistance. So combinations of antibodies engineered for potency and breadth and multi-specific antibodies are going to be required in order to maintain suppression. And these may need to be combined with antiretroviral therapies. And regimens in which virtually every virus is covered by two antibodies, plus or minus a long-acting antiretroviral therapy, will probably be needed. And just to point out, if you combine antibodies, what often happens, here's one antibody, and in orange and red are the viruses that are covered. These antibodies, or these viruses, aren't covered. Here's another antibody, covers these viruses and these viruses, but not these. When you combine them, what you still have is most of the viruses are only covered by one antibody. So when you do these combinations, you have to make sure that there's coverage by two antibodies. And that really means you need two broadly neutralizing antibodies in your combination. In this case, I think VRC07523 and 10E8 are two of the most broadly ones, and they or ones similar to that should be part of that combination. And with that, I'll simply stop. I won't name all of these people, but understand that a lot of people were involved in putting these studies together. And I'll stop at that point and take any questions you might have. Thank you.
So, Rick, in that mutant tri-specific antibody that you're
yes.
testing, does each arm of the antibody, when it binds to one virion, does it bind to that same virion, or does it catch another one? I mean,
yeah, it is unlikely that well, on a single trimer, that you'll get all three specificities binding, but by surface plasmon resonance or similar types of things, what we can show is that you can bind one arm. Then you can bring in a trimer and you can bind another arm and you can bind another arm, so that you can actually show that ultimately you can get three different trimers bound. But I'm not sure that that would fit stochastically, on a. But it will certainly increase your avidity, such that if you start to fall off from one arm off of the antigen, you'll have two other arms there to grab onto other epitopes.
Does it clump virions? Does it do that by binding to more than one?
Does it lead to virion aggregation or immune? Yeah, clumping. My guess is that it would. I'm not sure that we've actually looked at that.
So how about addressing, like we do with enriched therapy, combination therapy, the resistance that could be present in the population or emerge after treating people with long half-life antibodies? Does it concern you how you're addressing this issue?
So, well, there's sort of two aspects to that. One is that, this is not going to be different from antiretroviral therapy, except for the fact that everybody's virus that's currently circulating in them has been evolving in response to the neutralizing antibody that's developed within that person. So there's a greater chance that you're going to have resistance to some neutralizing antibodies than there is that you're going to have resistance to antiretrovirals to which you've never been exposed. But there is going to be resistance as a problem, and we're going to need to cover. The second part, or the second aspect, I think, of what you're asking is when you actually do clinical trials and you give a broadly neutralizing antibody, what do you do during that washout phase? So all of a sudden, you're going to have periods where you have subtherapeutic levels of these broadly neutralizing antibodies, and unless you cover those individuals during those periods with something else, you're going to start getting virus replication. You're going to induce resistance. So in the planning of these trials, we have to make sure, much as we did for efavirenz and other things, is to make sure that during that washout phase, we have adequate coverage through other means. And some of these washout phases are going to be extremely long, as you know. Yes, Stephen.
Rick. As you know, Mal Martin showed with Michelle Nuswag and others that if you give...
I was one of them.
Oh, you're one of them?
Yes.
Okay, so then then finally I will understand the truth as to what happened in that study.
Yeah.
But as you do know, they gave antibodies during acute infection, suppressed the virus, and as that the antibodies waned, the virus came up as expected, I believe, and then basically disappeared.
Yes.
Presumably, or I think there was some monoclonal antibody depletion data suggesting this was CD8 mediated. So what do you think was happening, and why did this not happen in people who were given antibodies in a similar situation?
So what I think was happening there is that during acute infection, before normal antibodies were being generated by those monkeys to those viruses, and you had lots of virus around, we went in with antibodies, and we formed immune complexes, and those immune complexes were taken up by Fc gamma receptor expressing antigen-presenting cells, and presented to the immune system. And there's actually a literature within LCMV and other viral infections in mice that is actually a mechanism for improving the CD8 T cell response. So I think what happened is that we got immune complexes, an altered CD8 T cell response, and so that some of those monkeys ended up then having a better CD8 T cell response. And when we looked at those monkeys later, in the original paper, we just looked at the blood, looked at the CD8 T cell responses, and we couldn't differentiate the monkeys who controlled versus those who didn't control. When we went into the lymph node, and this wasn't published, because we didn't do it until afterwards, the monkeys that controlled had better follicular CD8 T cells, so CD8 T cells that went home to the germinal center. Now, why do we think this didn't happen in humans? In the humans, we probably didn't give them the antibody early enough. Second of all, I think the latent reservoir is more difficult to control, and virus replication in general is more difficult to control in humans than it is in HIV-infected monkeys. So there's a lower bar in the HIV-infected monkeys for seeing these types of therapies work. And I'm not sure it's going to perfectly translate to humans.
So what is it in people that we need to fix to make this work?
We need to fix people? Well, I mean, we do actually have a nice research agenda going on, looking at how to induce with immune complexes a better CD8 T cell response. My hope is that ultimately improvements in CD8 T cell responses, plus all the things you're going to talk about, will end up controlling or clearing the latent reservoir. But I don't think any one of these arms is going to be sufficient in humans, and we're probably going to have to combine them.
Rick, a great talk. So, and a lot of data went by pretty quickly, but a few times you pointed out this lag that that was seen. And I guess maybe this is more of a comment than a question, but the antibodies have to get out of the blood into the tissue to do their job, and this happens much slower than small molecules.
Yeah.
So I suspect a big part of those lags is the antibodies getting to where they need to get to do their job.
Yeah, the initial modeling of this assumed that all the virus was in one big open bag, and we now know that it is somewhat compartmentalized. In terms of pharmacologic delay, certainly within the blood, there's almost no pharmacologic delay for antibodies, and there's very short pharmacologic delay for antiretrovirals. But you're absolutely right, and as I'm sure you're going to show us tomorrow, there is a delay in those antibodies getting to the mucosa and other tissues.
It was designed to invoke the commercial that you just gave me. Thank you. Tomorrow morning, 9 a.m.
Any more questions? Well, I have one last question.
Yes.
Then, from a clinical perspective, is there anyone exploring, of your knowledge, the possibility of clinical trials in HIV cancer, in the context of HIV cancer and broadly neutralizing antibodies? Because apparently we could think of bone marrow transplant, combination of broadly neutralizing antibodies, as well as treatment interruption that might be needed, for example, for chemotherapy, drug interaction.
So yes, there are certainly those types of trials going on. I think this is a perfect introduction to what Steve Deeks will probably be talking about, and certainly a lot of the exhaustion blockers, such as anti-PD-1, et cetera, which are being thought of for the cure, have been developed in cancer and have been looked at in people who are getting that type of therapy and are also HIV infected.
All right. Thank you, Dr. Koup.
Thank you.
Thank you.